Again, I'd like to thank everyone for coming in today. This is the 14th Complex Coronary Cardiovascular Interventions webcast. We're very honored today to have Dr. Khaldoon Alaswad, who is the director of the cath lab in Henry Ford Hospital in Detroit, Michigan. Dr. Alaswad is an established leader in CTO PCI. He is actually one of the experts in radial CTO PCI, which is only a handful of people in the world. And he's going to show to us some fascinating cases and share some tips and tricks of doing CTO. So, Carl, welcome again, and we're excited to have you on the webcast.
Oh, thank you so much, Manos, and say hi to Subhash. And welcome, everybody. Please feel free to ask questions. And I'm going to go ahead and start my talk. Again, I'm at Henry Ford Hospital, and this is my great hospital right in the front of the first slide. So I'd just like to introduce to the audience the Progress Registry, which is really led and executed by Manos and his group in Dallas. And if it wasn't without them, this would never happen. And it's probably one of the very good source of data for us so far. We are able to kind of understand the complex PCI, especially the CTO PCI, better by collecting our data together and have more information. These are some of the sites. I think since then there are more sites joined, and I actually moved to Michigan since then, and I made sure that to join the Progress Registry. We have several papers. One of the papers actually we presented, it was that you actually can do transradial approach for coronary chronic total occlusion. And this is something always been discussed and debated, and the Japanese showed like a 25 patient series, and it kind of opened our eyes, and that we can be able we should be able to open chronic total occlusion with completely radial artery access. And of course, the leader of this is actually Stefan Remford in Canada. And I got to tell you a little story. When I got Aaron Grantham to come and proctor me, I was still in Wisconsin. We did 3 cases, and the 4th case I did in my own, and the patient was really short and overweight, and we went growing then, and I almost lost the patient for retroperitoneal bleed after I opened the RCA that had been occluded for 21 years, and then decided as long as I'm radialist, why not also CTO radialist, and Stefan helped me greatly advance the technique. So the Progress Registry, we reviewed the data about radial artery access, and out of about 600 procedures, we have 16.9% of those procedures we use a radial artery access. 63% were like bilateral radial artery access. 7% we have bilateral radial and femoral, and 26% we use unilateral radial and femoral. That's what we call hybrid. And sometimes 4% of the time the operator chose to put only radial artery access. And if you look at the angiographic characteristics, most important out of this slide, if you look at the bottom 2 lines, that the difficulty of the radial cases was not any less than actually transfemoral cases, and a dual injection was used less, but I think this is just a kind of documentation. But anyways, the most important thing in this slide that shows that the distribution of lesions and the difficulty of lesions, in fact, in the transradial was a little bit more difficult than the transfemoral access.
Can I ask you, Carl, so do you usually go, what is your typical approach? Is it by radial or you do radial femoral? What is your typical, right now, approach for CTO?
And my typical approach is biradial, and the only time I don't go radial if the patient have end-stage renal disease or have any reason not to use the radial, like using the radial artery for a harvest. I don't check Allen's test anymore. I actually feel and palpate the radial, and I go. And I have to mention to the audience, I'm glad you asked this question, Manos, because when we published this paper, I was routinely using 6-French guide catheters from the radial, 90-centimeter 6-French guide catheter, and I chose a guide catheter that has the largest internal lumen. And I had really some difficulty sometimes, and when I failed, I actually switched to the femoral. But nowadays, I actually discovered that most patients in North America they are able to tolerate 7 French and 8 French. So I normally put 8 French guide catheter, now bilateral radial artery access. But I don't use the 11 centimeter sheath. I use very short 4.5 centimeter sheath. There are a couple of companies make those. One of them is Merit. And because the longer sheath the patient is less likely to tolerate by the shorter sheath. And of course, we can actually, if you couldn't put a sheath, you can put the sheathless guide. You can put either the pre-made sheathless guide, or you can just put your own guide sheathless. And we can probably talk about that if the audience are interested in knowing how
do you cut the sheath, or you just put the pre-made 4.5 centimeter sheath?
I tried to cut the sheath before, and it didn't work because the transition between the dilator and the sheath become really steep. So there is actually pre-made 4.5 centimeter sheath made by Merit, and the purpose of these sheaths are actually for the AV fistula. Those of us who fix AV fistulas, they use these sheaths all the time. So if you get them, if you have them in your lab and you want to put an 8 French in the radial artery, you can use them. If you don't have them, get them. They are easier than trying to kind of put an 8 French guide without sheath, because you always want the possibility of manipulating your guide. And once you put it sheathless, guide exchanges and manipulation becomes a little bit less favorable. So I'd like to put a sheath. So any other questions, please feel free to jump in.
And if you put an 8 French sheathless, how do you use a dilator, like a shuttle sheath? How do you get the 8 French guide in if you don't use the 8 French sheath?
Okay, if I cannot use the 8 French sheath, what I will do, I will actually obtain access with a 6 French and then put 035 wire all the way up to the arch. And then I will actually use the 8 French dilator just to dilate the track of the skin all the way in the radial artery. And after that, you have two options. Either you get 3 or 4 millimeter over the wire 035 balloon, and you put it through your guide and over this wire, and you can remove the guide and the balloon as a unit. You don't have to inflate the balloon, by the way. You just use it as a kind of as a rail, and you actually advance the balloon first in the radial artery, and the guide will follow, and then you advance them all as a unit. The other way, you can actually use 110 centimeter shuttle sheath dilator, 6 French or 5 French dilator, and put it through your guide and just advance them as a unit in the same way. But if you don't want to open a shuttle, you can actually use a 4 or 3 millimeter 035 over the wire balloon, and that will help you go through the skin and just advance it. Stefan used to actually inject Radioglide. Rotaglide, or the other one which is comes with the Viperglide. And I never did that, and I never had a problem advancing the guide through. And you have to remember, folks, like the outer diameter of the 8 French guide is actually 6 French sheath. And so if you go in with the 8 French guide, most of the time you are fine. You're not going to have problems, unless the patient is really small. So back again to our radial access. This is just to show you that it's possible to do the CTO PCI from the radial artery. And these are here the technical success and the procedural success. And the technical success, achieving less than 20% stenosis with STEMI-3 flow, and procedural success is discharged from the hospital with no complication, in addition to technical success. And if the blue color is the radial and the red color is the femoral, and there was no difference between the two procedures, and if you went from radial or went from femoral. And more importantly, the MACE rate was not any difference. So this is actually a little bit of point against doing it from the radial, because if you don't decrease bleeding, so what's the point of doing radially? Especially, I will show you the next slide. So my point is actually you need to have the skills of doing it radially, even if you want to stick to femoral, because a lot of times you can't do it femorally. And we all faced few patients that don't have a femoral artery access. More important, the operators who are participating in the Progress Registry are one of the best in the world. Like, they are the best operators in the world. So their groin bleed has to be less. So it's a very difficult to show less bleeding against people who stick thousands of femoral arteries every year, and they are very skilled operators like the participant in the Progress Registry. So result, procedure outcome, these are the number of stents, the contrast volume, and the most important thing, I want you to look at the red lines. The procedure time in the transradial was a little bit longer, and the fluoroscopy time was definitely longer. And that's understandable because back then I used to use 6 French guides. I think if we have 8 French guides, we still have probably a little bit more procedural time, but I think we're going to narrow that difference significantly. It takes a little bit more manipulation to manipulate the guide from the radial artery. However, at the end, the air kerma, if you look at the third line from the bottom, and this is how much radiation, total radiation the patient got, it wasn't statistically significant, although there was a trend toward increase in the transradial access. So you as an operator probably also get more radiation. This is when they looked at the radial versus femoral, radial access and femoral access was not a contributing factor to the success of the procedure, and these are the contributing factors to the success of the procedure. And you have a blunt or no stump. There was actually technical failure. We have no intervention collaterals. There was more technical failure. And when you have left circumflex versus LAD, and Manos and his group actually published this as a new JCTO score, which is the hybrid CTO score, which probably the paper, I think the paper is out now.
Yeah, it's about it's accepted, but you're right. It will be progress CTO score and these factors you mentioned. But it's very thrilling to see that, the radial did not make a difference in terms of success. And again, that's an experienced hands like yours. But I guess the bottom line is with experienced radial operators, this can be done safely and effectively.
Absolutely. And in conclusion, despite increased lesion complexity, radial access during CTO-PCI is associated with similar technical and procedural success rate, similar major adverse cardiac event, decreased CTO-PCI efficiency because of increased time and a procedural time. And as I said, this is still a moving target. So I'll be happy to entertain any questions. And I'm going to jump into kind of presenting my first patient to the audience and get Manos and Subhash input in it. So the first patient I'm going to present to you is a 57 years old male. He came in 2012 with acute coronary syndrome and received stenting in the mid and proximal RCA. Although the wire crossed in the PDA, the operator who called me said he could never deliver anything, and you can tell this from the angiogram. This is his baseline angiogram. This is done in outside institution in 2012. We're looking here at the LAD, and you can see kind of faint filling of the posterolateral branch and the PDA. So this is as you can tell, a huge RCA. There is a small circ which does not have significant disease, and this was the RCA at the end of the 2012 intervention. There are branches you can tell. If you can tell from this, you always ask about viability. Is the inferior wall viable? Is the lateral wall viable? If they are moving, they are viable. So this is just a proof that they are moving. So the interventionist kind of went in and basically did not really change much after the intervention. In 10 months, the patient came back to his doctor, and basically that was the angiogram with chest pain, and the PDA and posterolateral branch are still occluded. This is the LAD. There is a lesion, and you see that the apical LAD is feeding 2 branches, one to the posterolateral branch and one to the PDA.
And Carl, this is a CTO, right? This is actually a non-CTO, but it's a high-grade lesion. It looks like, right? It's a microchannel.
I think you could count it that way, but at the end it was probably we had to treat it as a CTO.
Sure.
There is a distal occlusion in the RCA. You can tell there. There is kind of reconstitution here, and I think there was a stent in there. It was really difficult to tell. The patient was morbidly obese, so our angiography can also limited. So the patient in November 2014 came to his doctor with this, and they did the angiogram, and they advanced medical therapy, and 9 months later he came to me. So
it's a CTO now.
it's a CTO now, exactly. So now it's a CTO. So and if you notice here, there are no catheters coming from the groin. This is an AL 0.75 with side holes. And I wanted to point out to you guys, this is actually the back of the J-wire. A lot of times when you're coming from the radial artery access and you're trying to engage the RCA, it's really difficult to manipulate the guide, especially if you're going to put an AL1 or AL 0.75 and it keeps slipping up. So what I do, I just go with the back of the J-wire very carefully and never through a kink, and I kind of straighten the guide and engage it and then I pull it out. So, but I never exit the guide with the back of the J-wire. It's going to help you control your wire better from the radial artery access. Helps you control your guide. Sorry. So this
Carl, can I ask you? Do you go from the left to the right? So this is the left radial going to the right and vice versa?
Absolutely. This is a very important point Manos bring in. So if you are doing it from the radial artery access, if you're doing a CTO from radial artery access, or even if you want a very good guide support, so the left radial artery access provides you with better support in the RCA, and the right radial artery access provides you with better support in the left main. And I would argue it's actually better support than even the groin, with the same size guide catheter, French-wise and size-wise. So if you go in radially, I'll always pick the left radial for the RCA and the right radial for the left main. However, if you are doing CTOs from the groin, you better make a rule and stick to it, because it gets confusing, so you don't forget. So my rule is to actually have the occluded vessel in the right groin. So if the RCA occluded, the GR4 or the L1 going from the right groin. If the left circumflex LID or left main, also going from the right groin. Some of our colleagues, they actually choose to do it differently, right groin, right RCA, left groin artery, so they don't forget in the middle of the procedure. You pick the different manifold and you inject antegrade after you perform dissection. You're going to ruin your chances of success. So back to our patient. As you can tell, there is actually occluded stent in here, and there is probably stent in here approximately. So this is basically good if you can get in the mouth of the stent, but you can't really make a decision on a strategy until you do dual injection and you see your occlusion segment from both ends. And I put a wire normally in my left main just to kind of stabilize the guide, and I think the wire protect the left main from the guide digging in and injuring the left main. So pretty much this is the dual injection. We injected antegradely a little bit late, but if you notice here, guys, there is a complete segment of occlusion in here. So now the decision is, and if you notice, I'm already inside that stent in here, and I have a Corsair a microcatheter, and this is probably my run-through. This is my workhorse wire. It's just a run-through wire, and this is another run-through wire. So I'm trying to decide how would I go with this. So if you remember. If you have the distal occlusion cap at a bifurcation and you end up dissecting antegradely, the dissection plane normally goes along one of the branches. Normally it does not track both branches. And I want you to watch in here at the end of the watch. Sorry, I'm going to have to remove this. I'm going to play it again. I want you to watch in here. Let's do this. This is actually shows it much better. This shows them up better.
Bifurcation and get to the distal cap, right? It's a kind of bifurcation, which is a challenge. But what do we think about the crossboss, I guess, trying to go 2 to true, 1 in 3 cases? That would be an option, I guess. But you're saying if it goes subminimal in 1, you're toast, right?
Exactly. So the stent was not reaching all the way to there. This is actually calcification, what you guys are looking at. So if I end up dissecting with a crossboss or with a knuckle, so the dissection will go over one of the branches, and if you stent, it might be very difficult to retrieve the other branch. So in terms of the hybrid algorithm, so we have wheel-defined proximal cab. We have occlusion probably 20 millimeter. With the tortuosity, we're looking at it here for shortened, I think more than 20 millimeter. There is, of course, distal targets are actually good, except they are at a bifurcation. And we have collaterals, which is, it depends on your level of comfort with collaterals and it depends on your experience. We can call them interventional collaterals versus non-interventional collaterals. So three years ago, I would not call those interventional collaterals because I would not go in a virgin chest. I would not go epicardial collaterals. I normally pick the septal collaterals. But at this stage, I actually start calling those intervention collaterals, and I feel so comfortable going through them. I would not advise anyone to go through epicardial collaterals first time without a proctor or without a previous experience with the septal collaterals. First time should be also in a chest that's post-cabbage, so there was not much pericardium to bleed into. So this is basically our occlusion, and if you want to calculate the JCTO score, there is more than 20 millimeter. That's score 1. There is calcification. That's 2 scores. What else? There is previous attempt. That's 3. Then you have a tortuosity 45 degrees in the bend, and no stump or stump. So we have actually JCTO score 3 here. And a hybrid CTO score, I think also 3, right, Manos?
Yeah, I agree. So for you would have, the good news is you do have an interventional collateral, I mean, for you, because, you know, it's one you could probably do, not for everyone, but I think you experienced operators can do it. And then in terms of, you have a tortuosity, which is an adverse parameter. It's not a circ, so you don't get that one. And then, so that would give you a 2, I guess, a number of 2.
Yeah. So we're going to go ahead and, no, there was a previous attempt and it wasn't that factor in a hybrid. So I'm trying to look here, and we have actually 2 collaterals, this one here and this one here. And I would pick the one which looks easier, which does not have much kind of hurts. It's the one that's straighter. The tortuosity in crossing the collaterals is more important than the size. So this one here has less collaterals, less tortuosity, sorry. So at this stage, because of the distal cap at the bifurcation, we are committed basically to retrograde access. So here the wire, this is a Xi'an wire with a Corsair 150 centimeter. Of course, my guide catheter was a 90 centimeter, and this is actually going into the collaterals I don't want to go through. So I just I said, okay, as long as the wire went there, I'm going to try it. I don't give up wire. If a wire goes somewhere, I don't give it up. Sometimes you'll be surprised. So this is what happened here. I couldn't get through, and I did not persist. I just, once the wire stalled a couple of seconds, I just pulled the wire, pulled the Corsair a little bit, advanced the wire, and the wire went right through into the PDA. I watch here, and like this is some tortuosity, and watch how the wire straightened the tortuosity. At this stage, we actually our.
So if I can say, you know, some of the may not be as experienced. So again, this is not something you do when you're starting CTOs. You must do whatever 50 or 100 retrogrades to the septals before you do this, right?
Absolutely.
So this is not for beginning operators. And it looks like to me like almost you are surfing the collateral, but you know you know exactly the course. So that was the other thing. People may think you're just surfing the epicardials. You don't normally do this. You just know where you're going.
Exactly. So in the epicardial, again, I advise the audience not to attempt the first, to cross them before they have 50 to 100 experience in septal collaterals. And the first attempt in the epicardial collateral, let it be in patient post-op. And actually, if you want to have a proctor, I think you should have a proctor with you the first time. So the question, the other thing, the classical, and I'm interested in hearing from Manos his opinion, and the classical teaching that you actually twirl the Corsair to dilate, but in the collaterals like this, what I found out, if you twirl the Corsair, you actually have more chance of ripping these collaterals. And what I start doing lately, I start advancing the Corsair just by gentle push. The minute I see the guide back out I start twirling. So I don't twirl as much, especially in the epicardial collaterals. If I can advance without twirling, I actually do that. Once the corsair stops, then I twirl it and I see. And I don't know if that's valid or not, but I think if you get in the corsair through a tortuous lemma and you twirl it, you actually might end up ripping that lemma.
No, I agree with you. I think it's you can just try just first to push, and actually even for septal, sometimes you're twisting. I had several cases, and then you just try gently push it, and it just takes its time and finally comes through by itself. So
exactly.
You don't necessarily have to go crazy about it. And actually, this one, quite often, at least we use a lot of fine cross for the epicardial specifically, and that's harder to twist anyway. But they have pretty good tracking, and they're very soft. So it goes with gentle pushing and patience.
Absolutely. I use a fine cross if I fail. So it's very important here to get your corsair all the way to your actually distal cab retrogradely. And now we see in like that, if you notice, the tip of the knuckle, antegrade knuckle and the corsair, they're dancing. They are in the same plane, in the same vessel, and so they are very close. All what I need to do now is basically to puncture retrograde. However, there is a stent. If I puncture retrograde and it dissect around the stent, and this might be undersized stent, I always assume that occluded stents are undersized. If I want to dissect around it, I'm going to be committed to crushing that stent instead of kind of opening it again. So there is a stent in there, and I actually made careful to kind of wire through that stent retrogradely. And in fact, I was able to cross true to true retrogradely with the wire, and I actually wired my guide catheter. Now,
what wire was that, Cal? Was it a pilot or a Confiante? What wire did you use to cross retrograde?
I think I actually used a Gaia first or second.
Okay, great.
And so now this has become now a complex PCI, because if you notice here, we have a huge posterolateral branch, and we have a huge PDA, and there is a lesion at the ostium of the posterolateral branch, and there is a lesion in the proximal posterolateral branch, and we have a distal RCA lesion. So how to approach this bifurcation? And you have to remember, now you have an externalized wire, so you can't really remove externalized wire that easy unless you want to switch to antegrade technique. So we can actually, I don't know about the audience, but you guys can vote on this. Do you do provisional stenting? I will stent in the PDA over. Now remember, your wire is over the PDA. I'll stent over the PDA and then pull and just kind of hope for the best and see if we can need to stent it. Do you do culotte, V-stenting, kissing stenting, DK crush, or tap? And you have to remember, you have an externalized wire, and this problem I've been facing lately because we go retrograde and now we end up having to fix a bifurcation. You cannot do culotte because you have to pull your wire and recross again. So the culotte option is out. The tab and DK crush and kissing stenting and V-stenting are actually in, but you have to put a wire antegradely into the side branch and use the retrograde. You can do that, but you cannot do culotte, and you cannot do what else you can do. You can do provisional stenting. So culotte is out. The rest of the options are available to you.
But mini crash too might be an issue, I guess. The mini crash might be hard. You still have to remove the wire and rewire. So.
Yeah, but in the side branch, I actually either tab or mini crush. So I chose to. We are an educational institution here in Henry Ford, so we decided to go DK crush, double kiss and crushing. So basically, what we did, we double kissed in the bifurcation, and then deployed a stent in the posterolateral branch because there is a significant lesion. There is a balloon in there I'm crushing. I have to kind of pull the posterolateral branch. I use run-through wire to cross again. I use the corsair to cross through the crushed stent, kissed again, and then put a stent, then stented, pulled the wire, stented, then recrossed, and kissed finally, and this is the final kiss. So now after you've done this, you need to basically remove your retrograde wire. Now remember, always you need to push your corsair, that retrograde corsair, to all the way to the guide. However, if you have the whole RCA stenting, you don't. And the reason you need to do that when you remove your externalized wire, because if you're pulling an externalized wire and it will act as a cheese grater and it will cut through the flesh of the RCA. So I advanced the corsair retrogradely to the stented segment, and this RCA is stented all the way to the ostium. So I didn't need to advance it all the way to the guide catheter, and this was our final picture. And I want to bring your attention to, look at the end, the PDM posterolateral branch. Look that they are cut off, and they are actually not. It's just this is competitive flow from the other side, and so don't go looking for thrombosis or clot. It's just competitive flow. Make it look like cut off. So
beautiful result, Carl. That's excellent. And so what you did is you deployed your stent in the posterolateral, you crossed it, and deployed the stent in the PDA, and then you recrossed in the PLV, and then did the KISS, right? Is that what you did?
Absolutely.
And it looks beautiful, huge stent, and great result.
Yeah. So I actually kind of trying to understand. I know whenever I go through occluded stent or end-stage stenosis, I always IVUS. And I try to understand. So I IVUSed, and for some reason I probably forgot to put the images for the IVUS. But that stent, it was 2.5, and one stent 2.75 in the distal and the proximal RCA, mid to proximal. And the vessel was actually 5 millimeter. It was these old stents were so small inside the RCA. And that tells you this patient came with acute coronary syndrome. He probably have a lot of spasm, and sometimes the vessel just kind of relaxes later, and you have an undersized stent that will definitely close. So I'm not sure how to solve this issue, other than you have just to remember that give plenty of nitroglycerin before you decide in the size stent you're going to put in RCA if you see the patient. This patient tells me he walked 2 miles the next day. He actually got up in the hospital and started walking, and he calculated that he walks 2 miles. He's a software engineer, so he knows, and he had no chest pain the next morning, and he went home. So this is basically this is a case where how to do retrograde access and what to choose and the techniques. And once you've done retrograde, if you want to do bifurcation stenting, what kind of problems you end up facing and how to go around them.
And I think there's a lot of interest, Carl, lately on preserving all the side branches. In the past, we said, whatever, just open one branch and you'd be okay, better than nothing. But I think we're increasingly seeing that if you recanalize all the major branches at least, you feel better. You have obviously less ischemia and less stenosis because of better outflow from the vessel. So the latest trend is to try to go for complete and keep all the major branches open, as you just did in this case.
Absolutely. And I will try if I have to do a subintimal dissection, and especially when you do a reverse cart, I'll try to make the reentry right in a occluded segment to kind of preserve all the side branches. You never know; these could be a source of collaterals down the road, and we did show, as actually Manas showed, that 8.7% CK elevation post-retrograde cases. The Japanese and the J. Proctor showed also similar results in their registry. So we're trying to minimize, probably this is because we actually have longer tracking and more side branches get lost. So we're trying to minimize that as much as possible. So on to our next patient, which actually this is a debate how to do what to do about these patients. This is a patient, 74-year-old male, with known lima to the LAD, very old, lima SVG to the RCA and SVG to OM1. And this patient in 2009 comes with this picture. He had basically occlusion of the LAD distal to the lima. If you look in the right here, he has occlusion of the OM1 of the circ and the LAD. And this was the SVG to the first obtuse marginal, and this was giving collaterals actually to the distal circ, and that was the SVG. So in 2009, we treated this. We put a filter wire and we treated it, and look at these results. You still have shown like there is thrombi or clot in there, still kind of moving, and if you look, we're not really sure what happened. So we chose to put a bare metal stent back in 2009, and of course that comes back and bites you in the butt. Instant restenosis in 2012. No other changes. LAD has CTO distal to the lemma, mid-circ CTO, and RCA still CTO. So that was treated with drug-loading stent this time with a lot of difficulty. Now, fast forward 2015, I get a phone call that this patient presented to outside hospital with a thrombus in the same SVJ in the obtuse marginal, cardiogenic shock, had an impala, very complex intervention. The interventionist tried to advance the filter, deployed the filter, could not advance anything over the filter, and I'll later let you know why he couldn't advance anything. While struggling, basically the filter, everything comes out. And he pulls the filter out, and the filter is just full of atherothrombotic material. The patient in cardiogenic shock, fortunately did not have a stroke. Stabilized in the floor in the impala. They went to remove the impala in a couple of days, and he had significant bleeding. They have to repair the common femoral artery. The patient continued to have chest pain with minimum, this is assertion, it's exertion. I am so sorry about that. And so the patient basically was transferred to our hospital. So he was still kind of weak and recovering from cardiogenic shock, and the decision was what to do. We have that SVG that tried to kill the patient 3 times so far, 1 time with primary failure, second with instant restenosis, and now with the stent thrombosis. I don't have these films to show you. I actually have the films, but I can't download them to my system, so I couldn't make AVIs from them, but trust me on that. So we decided to basically perform complete revascularization. The RCA, CTO, PCI, we tried to do that. When we went to take a picture, the stents and the graft was open, so we went in the left main and the RCA, trying to avoid poking the lemma or the SVG again. So we went through the septals, and we were able to get all the way through, but we could not connect the dots. Finally, I decided, okay, what I'm going to do, I'm going to go back into the mid-circ, and I'm going to perform star technique, and after that, I'm going to bring him back and do it. And the star technique, what you do, you basically knuckle the wire, and you push it until it pops in back in the vessel. So we used in the past to kind of stent that segment, and an Italian group, I think Marino, I can't remember who exactly, but showed that there is 53% reocclusion when you put a stent. So what I've been doing lately, after I do knuckle dissection, I do just balloon angioplasty, and I bring the patient back within 2 weeks to 6 weeks, and then I'll find either reocclusion, but I'll be able to find the true lumen, or I'll find it open and stent it. And this is what happened with this patient. We brought him back in about 4 weeks, and this is basically the vessel. This is the result of basically knuckle and just ballooning. So the RCA, you can see the RCA is still included here. The septals that I used, they're still feeding the RCA. And so at this stage, this graft, this is the picture of the graft in here. And I'm not sure if you can see it correctly, but if you look here, he had a bare metal stent here, and he had a drug-eluting stent here, and that at the junction, there is actually stent fracture. And I actually had to look, and in hindsight, I found that. But then, and this is open for debate, what to do with a graft that tried to kill the patient 3 times. Do you, even if it looks open, there is a good flow in it, and we're trying to determine the answer to that question. But I decided in this patient, I'm going to open the native circulation, and I'm going to basically see what the graft's gonna look like after I open the native circulation. So as you can tell, we're coming from this is here coming from the radial 8 French EBU, and this is coming from the groin because I could not really engage from the left radial in here. So I'm coming from the groin with an 8-French AL1 and still not engaging that graft. And that kind of tells you the difficulty the previous operator faced. So we have...
And sometimes I think if you have the graft stand all the way out in the ostium, then it might be very hard to engage them because the stand kind of acts against you.
Exactly. So we basically put a wire, and this is a guide liner, push it in here, and this is dual injection. And this segment, this is the OM, that's where the graft goes. So I looked here, and I thought, okay, well, this should be easy because it's actually probably, this is a functional occlusion, not a true occlusion, meaning when you inject both sides, you can see basically flow. So in this segment, you have a graft and you have an antegrade, and you probably have a microchannel here. So what I chose to do, I chose to go antegrade, my first choice, in trying to get it really, because I thought I can get through this. And lo and behold, actually the wire went right through and went retrograde this way. I think this is even a run-through wire. This is my workhorse wire. There is a fine cross catheter following here. That's it here. And if you notice, I'm trying to push the fine cross, and look how my guide catheter is backing out. And this is an 8-French guide catheter coming from the radian, and I use EBU 4. I don't use EBU 3.5 or 3.75. So this is a really very aggressive guide, and it's kind of kicking back. The wire crosses, and nothing will cross. This is the Corsair. What I did, I introduced a balloon inside the SVG. This is 4mm balloon. I trapped this wire retrogradely, and I'm trying to push, and I couldn't go. This is actually a turnpike microcatheter. Look at the guide backing out. This turnpike tip was damaged. The wire was damaged. Everything was damaged. I had to pull the whole system out and go again.
Carl, did you do granatoplasty in the beginning? You break any balloons there just in case, or?
I did. 1.5. I think this is the 1.5 millimeter. I could not push it at all past this point, and try to explode it. I think I did it, or I just gave up because I could not get close to it, because this is where the Corsair stopped, and I could not get it. This is 1.2 by 20, same thing. And I'm
curious if you had any threader or any glider balloons. This can work pretty well in these lesions too.
I don't have a glider, but I have a threader, and we tried it, and it didn't go either.
Nothing works, huh?
Nothing works. We had a fine cross,
no laser,
a turnpike. Okay, so I actually called for the laser, and my EP colleagues have it in the OR with the lead extraction, and they said it was about 2 o'clock in the afternoon, and they said they're going to be done with it by 7 p.m.
That's helpful.
I know. So even I thought, okay, I'm going to wire this with the rotor wire, and I'm going to rotor blade it. And lo and behold, I was in room 4, and room 3 had the rotor wire, had the rotor console, and we only have one console. So what would you do?
That's a good one. So you tried all the balloons, it didn't work. You tried guide liner or any anchor or any support. You did the reverse anchor on the graft. It didn't work either. And then you said that you don't have threader, the glider. You tried a bunch of balloons. You broke them. Didn't work. I guess the next step, again, laser. You don't have a laser. Rotablator. You don't have a rotablator. There's some technique that Japanese have done, which is called the cutting wire. So you put a second wire through there, and then a balloon over the first wire as far as it goes, and then pull the wire back and kind of cuts the ostium of that entrance into the lesion. Which again, it's interesting. I don't know if you can get 2 wires through there, but if you could, that would be something that could be done. Another option would be to just go subminimal. Just go subminimal and crush it and get back in and do an external crush, like you've done where you go outside, put the balloon outside, crush the calcium, whatever it is, and then the initial wire you had to lumen, you can use that to stand, and that's easier to go after that.
So if you went subintimal, how do you ensure that you're going to go back into that graft?
You don't. That's the cut. That's the cut. No, I agree. This is a very challenging situation. I'm just saying, if everything else fails, what I would do is leave the wire in the true lumen, that you know it's true lumen and everything, and then go with a second, either an oversized balloon, dissection proximally, then follow it up with a Pilot 200 or a Fielder XT, and kind of knuckle your way around that bend. And then just use this. I would just use it to balloon outside that area of resistance, so you can deliver stuff through your true lumen wire.
Okay. Actually, that's a very great idea. That you described this in one of your case reports, like external anchoring and also external crush. You can dissect around it. So what I did, I said, let me. I haven't performed a cart in a long time. So this is basically, I think this is a Confianza Pro 12 wire. I'm going retrograde, and actually wired retrograde, and in the same spot. This is the spot exactly. My retrograde wire, this is the fine cross coming retrograde, and I simply, what I did, I basically knuckled. So this is the integrated wire, and this is the retrograde wire, and this is here sitting outside. See, guys? Sitting outside the
resistance area.
Yeah, and look at this. Here, I'm just pushing a knuckle. I just wanted to knuckle. I just want to destroy the whole thing. But I just made sure that my knuckle does not actually destroy my circ. But so I pushed the knuckle, and the knuckle went all the way to here. See it? So this is the knuckle. And over the knuckle, I actually advanced a retrograde balloon through the graft. This is actually the guide liner all the way almost to the end of the graft, outside balloon, and I crushed from the outside.
Great.
Basically, and then I actually, I was able to, after I crushed from the outside, I was able to advance a microcatheter antegrade. Did not externalize the wire. I just treated antegradely, and then we basically wired antegradely, and then I used the Xi'an wire to flip down and go down the large OM, and now I exchanged the two workhorse wire. I think I used run through here and ballooned it. And then, if you look here, I had to use a guide liner here because the guide liner basically helped me deliver the stent all the way to here. This is injection in the graft. This is basically where I kind of was struggling, where I had to destroy the vessel, and so this is a 4mm stent. We deployed that stent, and we deployed a proximal stent, and this is basically our almost final results. So here, this is 4mm. I went back and basically dilated it with a 4.5mm balloon because I want to jail that graft. At this stage, I wanted to kind of make sure that the circ, this is the true lumen in the circ, this is here. We simply just did a V-stenting just to preserve access to both of them. And we got these results. So this is the circ. This is the branch still actually feeding via collaterals from this OM, and this is where we performed the reverse cart, and this is the RCA. So now, what to do about the SVG? What do you think, Mark?
Leave it. I know it's a big debate, right? I must say I'm biased about this. In my mind, if the SVG is hurting you, so if it's like has an aneurysm or a lot of thrombus or something, fine, I will close it. But in this case, I think so there are some cases where things can happen. You put a lot of stent in the native, so we're going to go fine. But I'm not sure that would coil it because not going to good something happens. You may have a second option, and if not, if the vein has a poor flow, it's going to close by itself potentially. But I understand there's a limitation. You might have competitive flow and potentially damage your undergrade flow and cause issues there too. So personally, I wouldn't, but I don't know.
Okay.
I know it's different opinions on this thing.
So Stefan, close them all. Aaron keeps them open. You keep them open. I'm actually selective. And I'm selective because when I see a lot of competitive flow, and what I did, I made sure that to jail the insertion of this graft by a stent, but there is a lot of competitive flow. And this graft has a stent fracture, and every time I tried to deliver the device through, I could feel that getting stuck at the stent fracture in there. So this is basically, after a long thought and debate, I decided to coil it. This is an Azor 018. I actually had to change my guide to a hockey stick. The hockey stick actually sat better than the L1. There's still the guide liner then. This is the Azor going all the way in, and this is the Azor being deployed. The Azor, those have a battery. You plug the wire in, and it will separate it So those are repositionable as long as they are still attached.
And what size was it, Carl? Was it a big one?
Yeah.
A big coil?
It was like 0.8, about 20 centimeter long, and I jumbled the whole thing in here. So normally I like it to kind of close all the way to the stent, but I did not dare get it closer to the stent because I did not want the coil to escape and go down my native circulation. And then I placed 2 figure-8 coils, and it's kind of just to kind of ensure that this SVG gonna thrombose, because I was worried about competition with my native circulation and stent thrombosis. And I want you to kind of watch in this picture. The problem actually Aaron Grantham brought, like if you have a circulation going into the native and back out of the graft, and you have atherothrombotic material in that graft, like what you can see here. I want to bring your attention to here in this area, some haziness. You could actually embolize this outside the graft, and that could go to the brain. So the question, this is one of the arguments that those of us who close the graft have, that you could actually embolize retrogradely. I actually, as I said, I'm selected. Go ahead. I didn't hear the question.
I'm sorry. I think there was some noise on the background.
Oh,
but
okay.
I think what they were saying is, do you coil all the way distally, or are you coiling also proximal in the graft, kind of both ends, to kind of stop the flow?
I actually just put a coil distally, and I'll leave it get plugged. I actually don't like to kind of fill the whole graft with coils, and the reason is because those coils, they're going to stand in your way to do angiogram. They overlap with your native circulation, with other graft. So I don't like to kind of fill the whole graft with coil. I just like to coil as proximal to the distal vessel, to the native vessel as possible.
And you let it close by itself, right?
Yeah, and normally those work around. But I want you to see this picture. Look at the graft. So this is one of the figure 8. So when you inject in the native circulation like I'm doing here, you better be careful not to push the coil all the way back up.
Man, this is scary, actually. This is scary, seeing it fly back and trying to get detached. I mean, thank God it didn't move very bad. I imagine this went all the way back. That would be a problem.
That would be a problem, exactly. So
it makes you wonder, actually, if it's better just use the long coils and avoid the smaller ones. The longer are probably more likely to stay in place than move.
Exactly. Yeah. So
did you put another one on proximal to jail those figure 8 or?
So no, I did not. So once I saw this, I stopped. I inject the next time more carefully, but still kind of pops it open, and so I put a big one distally so I can jail those figure 8. But I think I should have put another one here to just, but we had to run to IR because I did not have my interlock.
Sure.
So I didn't want to run again and have it. So we said, okay, as long as it's staying in, we're going to leave it alone. So the patient went home the next day, and his chest pain, he has some musculoskeletal chest pain, which improved after we did the first star technique, the other cardiac chest pain. He still have that musculoskeletal chest pain, and we're going to bring him back to fix that LAD and RCA. But I'd like to fix the RCA first before I go through the lima.
Yeah, I think, Carl, this is a great example. I think you mentioned it before to me as well, that at some point in the future, or the present in some centers, this might be the preferred therapy for degenerated vein grafts. Instead of operating the vein graft, I think with better techniques and like the way you just described very nicely here, maybe that's the better short-term and definitely long-term patency, and less chance of embolization and all these issues you had in this patient.
Absolutely, and I think this is a question we need to answer. There are a lot of doctors still treat SVGs, and this SVGs was treated 3 times. And the last time it caused cardiogenic shock. So what to do about this SVG? And it's like I think the data, if you look at there are several papers, and if you look at the ISAR cabbage, and if you look at all the data, the MACE rate of SVG intervention is still high, about up to 24%. Once the SVG degenerate, most of them will reocclude within a short period. Most of them will refail again, and the intervention is difficult, and the target vessel revascularization is high. So if you have the skills to use that SVG to go retrograde like what we did here and open your native circulation, the worst case scenario in the native circulation CTO PCI, that you have less MACE rate than SVG PCI, you have less no reflow phenomenon, and that target vessel revascularization is actually, most report shows better target vessel revascularization. Of course, these are two issues never compared head-to-head, and I think it's time for our interventional community to probably demand a trial to see if it's better to fix the CTO of where SVG has gone closed or basically degenerated versus trying to mess with those SVGs that you know for sure they're going to reclose again.
Exactly, and especially in view that people are getting more familiar with CTO techniques now, more experience and better results than they did a few years ago.
Yeah, absolutely. So
sounds perfect. Yeah, that was a great case, Carl. Yeah, thank you very much. I think we're actually almost. It's 2 o'clock. So there is one question that people were asking. They were asking on this case. The question was why you went retrograde versus antegrade with this loop.
Okay.
When you couldn't get the equipment.
Yeah, I could not deliver anything in the antegrade. We crossed through the true lumen antegradely, but we could not cross with the wire, but we could not deliver anything. And I did not have the laser available at that moment. Even the rotoblations didn't have it. And in fact, I actually tried to dissect around that segment, and I couldn't dissect around my artery because I wanted to dissect around the wire crossing and crush from the outside. It was so hard for some reason. So I went retrograde, and I was able to do it retrogradely. And as long as you have the SVG there, I just took advantage of it, and it was so easy. And especially the orientation of the SVG insertion is kind of tenting that obtuse marginal. There wasn't any difficulty in wiring retrograde through the vessel, and in that way, I was able to basically dissect retrograde and crush from the outside, and basically advance my crush the area where I could not deliver devices from the outside retrogradely, and then I was able to deliver these devices antegrade. So I went through lumen in the whole segment antegradely.
Perfect. And I think you're absolutely right. I think what happens also sometimes you have so much scar tissue down into that anastomosis area that your wires may not go even as a minimal, whereas it's much easier to do that retrograde. So again, that's something very unique. Again, obviously for the audience, this is not something you do every day. This is for very experienced operators, but it's something, a last resort technique to be able to cross these balloon uncrossable lesions and get the success.
Absolutely.
So, Carl, thanks again very much. These were two wonderful cases, a great introduction into the radial approach. Thanks everyone for being on the call, and we'd like to thank also our sponsors, Terumo and Upper Vascular, for supporting this series. And any questions you have, both Dr. Alaswad and myself will be very happy to get to you. So thanks so much. And Carl, any last words?
Yeah, it's It is a moving target for our interventional community, and it is, if you don't try, you never know. So some of these techniques we're not common just 10 years ago, and now we are doing this more frequently. And this is our field. Like, it's just a moving field, and we have always to be on our toes and learning new techniques. And I think in 10 years from now, this is going to be a common practice. And please, guys, we need probably grassroots movement to push for a trial that compare SVG PCI versus CTO PCI.
Great points. Thanks again, Carl, and again, thanks to everyone for attending on the call.
Okay. All right. Thank you so much.
Bye-bye.